Welcome and thank you for joining me today. I am Allison Berard, the Senior Director of Behavior Support Services at Easter Seals Northeast Central Florida. And today we will be talking about compassionate care and what to look for in an applied behavior analysis provider or ABA provider. So the first thing we'll talk about is what is applied behavior analysis. If we break that down into the three terms that it is comprised of, we get applied, which means that we are working to apply behavior change that improves people's lives. The next is behavior. We are looking at behavior that is observable and measurable. So we can do analysis and see if there is a reliable change with the interventions that we put in place. Now, this is a very brief history of not only how applied behavior analysis came about, but also how it is used as a science for applied settings and working with children with disabilities. So firstly, we look in the early 1900s with Dr. John B. Watson. He was a psychologist who was pushing the theory of behaviorism. He coined the term stimulus response psychology, or the concept of stimulus response psychology, and said we really need to be looking at things that we observe in our environment and not relying on internal states that we don't have access to and we can't see. Next in 1930, so we've skipped ahead a few years. I'm sure there is other analysis and experimentation during that time, but Dr. B.F. Skinner in 1930 coined the term radical behaviorism, which does acknowledge that private events exist, but also states that those in and of themselves are behavior to be explained. So basically, the outside environment and the world in which we live is not only working on the behaviors that we can see, but it's also working on our internal states. And that's something we should look at as well. In 1949, P.R. Fuller had the first documentation of behavior principles to teach a child. So the particular and it was an older teen he worked with, was severely limited in mobility, so could not function physically on their own or engage in physical movement. And he actually used a little bit of sugar water to reinforce movement of the child's arm and was successful at reinforcing that behavior, which in turn could lead to a better quality of life for that child. In the 50s and 60s, multiple researchers worked to determine behavior principles, and outside of the laboratory, how could those principles be used to improve human life? In the mid-1960s, Dr. Lovas did some work with children diagnosed with autism in a clinic-based setting. He had a lot of rigid and to this day would seem as though undignified procedures and techniques that he used with the children. The successes of the study was that about 50% of the children were indistinguishable from their peers in a school setting. So, we can take a lot of the good lessons and pull those out and apply them to what we are doing today in a more, compassionate and ethical way of treating children. In the 1970s, Dr. Murray Sidman, whom I had the pleasure of meeting, worked on using discrete trial teaching with children and other populations, where he had a very systematic way of presenting stimuli, waiting for a response, reinforcing that stimuli, and then changing over to the next trial. So it's a little rote in its in how we present it, but it was a big event for the field in how we apply these teaching techniques with the children that we serve. Next, in the 1990s, 1999, and 1998, 1999 are when they published their first papers. Sundberg and Partington coined the term natural environment teaching, which does use some discrete trial in a way, but is more child guided. So we have child-led activities, and within those activities that they show motivation and interest in, we are providing learning trials so that it is a more engaging experience. And with these two procedures combined, we can get a lot of effective behavior change and skill building for children. And then current day, as recent as the 2020s and onward, our field has been exceptionally interested, which is a wonderful thing, in compassionate care and ABA. So there has been a big cultural shift from these really strict ritual rules of how we teach children to evolving state more geared at emphasizing child assent, their dignity, their desire to want to learn, and building on that to be successful in our practices. So we're really excited to be a part of applied behavior analysis at this stage of the game, because we're getting not only the good results from the historically evident procedures and the historically effective procedures, but we're doing it in a way that is more effortful in relying on human dignity and the desire to learn. So next up, what is a behavior analyst? I won't go through all of this with you. I just want it to be very clear that a board certified behavior analyst, and in some states a licensed behavior analyst, will have a degree in related coursework. They will have specific behavior analytic coursework on top of their bachelor's or master's degree, depending on what level of certification they are. They will have supervised field work. So if you look down there in the bottom right, it is comprised of between 1,500 and 2,000 hours being supervised by somebody who is already a BCBA and has been a BCBA for over a year. At that point, they can enter to submit all of their completion of coursework and fieldwork to the board, and they have to pass a pretty hefty examination. Once that happens, then they are fully certified. And only at that point can they begin serving families in an independent behavior analytic way. Once they have this certification, that does not mean that they are able to serve everyone and know everything about human behavior. They must still work within the scope of their practice. So a lot of behavior analysts follow a certain trajectory within, they want to work in the field, and they will work often with children, geriatric populations, veterans, human safety. We see that a lot in businesses and in roadway work, all those signs that help you slow down or acknowledge that a light is changing. Behavior analysts sometimes have a role in that. Working with animals is another opportunity they may have. So what that means is that behavior analysts have to work within the scope of their practice. So if they are not adept at working with children on feeding skills, and they have never been taught that, and they've never experienced that or had supervision in that area, just because they're certified doesn't mean that they can work with those children on those needs. So when you meet your behavior analyst, if you're interested in participating in an ABA program, it's really important that you know they're working within the scope of their practice and they have experience with what your child is experiencing. But at the very least, you can go to the bacb.com website, and when you first get there, on their homepage is a button that says Verify a Certificate. And if you click that button and enter in typically their name, but you can also do it by state to see how many analysts are in your location, this will tell you if they have an active certification or not. So it's important to start there and know who you're working with. Next up, behavior analysts have to follow an ethics code for behavior analysts. The analysts have this at their level, and then we also have ethics codes for RBTs as well. It's a pretty strict code, and it's comprised of core principles and ethics standards. We want our BCBA, if you're working in an ABA program, to be fluent in these codes. And then not only be able to talk about them, but follow them in practice. So I won't go through these with you in depth, but they are listed here by six sections: responsibility as a professional, responsibility in practice, responsibility to clients and stakeholders, responsibility to supervisees and trainees, so those serving under them as RBTs or BCABAs, and responsibility in research if that's something that you are participating in. So they have to uphold these standards in their practice, and it's really important that you not only pull this, I recommend you pull this from the website so that you are familiar with it as well, but that they are able to fluently speak about it as well. Okay, so who can behavior analysts work with? Oftentimes we believe that we are restricted to certain populations, like those with autism spectrum disorder, because that's sort of how we hear about whom we work with, either on social media, or if you have a friend of a friend who has children with autism and they have ABA services. But the truth of the matter is we can work with anyone. It's a science of human behavior, and the learning strategies are created from, basic laboratory science, and that's applicable for all of humanity. So that's the exciting news. We do not require a diagnosis. We don't require a doctor's referral or any specific problem behavior. With that said, our funding sources often do. So funding for applied behavior analysis services, such as through insurance, may and often do require diagnosis, a doctor's referral, and very specific demonstrated problem behaviors. So just keep that in mind when you're trying to obtain services, and look for an agency that is pretty savvy in navigating those requirements. All right. So what happens first? The first thing that we typically do is start with a behavior assessment, which will look at your child's history. This involves a thorough review of medical history. We want to rule out anything that could be addressed with medical interventions or medication. For example, we've had some children that had some serious bouts of head banging, and were unable to communicate with us what was going on. And it would turn out that the child had severe pain in their head due to ear infections. So addressing ear tubes or, that ear infection was able to reduce that behavior of head banging without intervening in with behavioral techniques and procedures. So we certainly want to do that first. And we want to talk about the duration of behaviors of concern. So did this just start? Is it somewhat age typical? Children, as they grow, learn new and different ways of doing things. Some are not always appropriate. Some are not always desirable. And often with this simple change in maturation, we can decrease these problem behaviors. So that's something we should look at too. Is this kind of a normal standard within typical development? They will look at their skill deficits. The first thing they want to do is discriminate between if this is a can't do or a won't do. If a child has the skills but just refuses to do them, then that's something we can work on from a behavioral perspective. If it's the case that they're not doing them because they're missing some prerequisite skills, that needs to be identified first. Because without teaching those prerequisite skills, we could be creating lots more problem behavior for you. This is a big term coined in our field called motivating operations. Basically, what's motivating them to engage in certain behaviors? And do you as a caregiver have the ability to manage that? So sometimes kids are motivated by attention or access to toys and things that they want. And as adults in their life, we have the ability to manage access to that based on if they are behaving appropriately. So if you ask me kindly, I will give you this toy that you want. Something in that vein. However, if something is motivating them, that it's an internal state, such as scratching at a bug bite that really itches, yes, I can put medicine on it, but I can't control how severely that itch feels or how it feels once they started scratching it. So I don't have access to that as easily as I do the toy. So that's something your behavior analyst would look at and determine what we can easily contrive for them to access things for good behavior and not give them access for things when they're acting in ways that are not appropriate or functional. And then the last one should be a core component of an ABA program. So it should be based on regularly providing good things for good behavior. That should be the bulk of the whole program. And any other procedures in place should come secondary to that reinforcement procedure. Lastly, I want to note that all of these things, again, should be taken on within the scope of the analyst training. And then also, everything they're looking at should address the core deficits of a child's disability or diagnosis. So, for example, with autism, that might be social skills. For a child displaying ADHD, that might be executive functioning skills. So, if your program or plan looks like something that is taking on tasks or activities for the child that don't seem to be core components of what they're dealing with, then that should be a red flag to ask a lot of questions and see how the program might build upon that or where they're going with those particular lessons. The next thing that they'll want to do is find out what a child's function is as far as particular behaviors go. So when we're looking at our target behaviors, which are typically maladaptive behaviors that we are looking to reduce, we want to know, are they being provided attention for those specific behaviors? Are they getting things or items for those behaviors? Are they getting to leave a situation that they don't enjoy because they engage in these behaviors? Or is it just something that is affecting one of their five senses? And so they're interested in it for that reason. From this information, your analyst will develop a plan. And here are some key components about your plan that should be provided to you when they are done with it. And you should sign off on it as part of your informed consent when a BCBA is working with your child. Plans should be detailed, but they should not be so technical that you cannot understand it. It's really important that whatever they say in there makes sense because you, as a caregiver, will also be held accountable for following this plan just as much as teachers or the analyst will be. The plan should state where the child is at currently and then what goals they're trying to reach with the plan. There should be very clear criteria for skill mastery. So, how do we know when they've learned a skill? Plans for generalizing that skill to natural settings, meaning that if they can do the skill in a therapy room or perhaps in a playroom at home, but they can't do it on the playground with their peers or they can't do it in the classroom with their teacher, then we haven't quite taught them that skill in the way they need us to. So that's what generalization means. It should also detail parent involvement and the training required. If no part of the plan talks about how parents will be involved or caregivers will be involved, then you need to thoroughly discuss how that looks with the BCBA and likely get that added into the plan so that you know you'll be supported as well as your child. And then lastly, what is the criteria for program mastery? It should be a concern or red flag if a behavior analyst is recommending 40 hours of therapy a week, but they can't detail when the plan will be identified as meeting all of the skills and moving on to the next setting or decreasing hours in therapy. Some children do not need 40 hours of therapy. Some kids need 3 hours of therapy. Some kids need 20. But that should be outlined by the goals and the criteria of mastery that they put in their plan. It should be very clear how the analyst is going to monitor the plan. When and how often will they be updating the plan? Typical frequency is weekly, but this can be shorter or longer depending on how fast your child is acquiring skills and how often they attend therapy sessions. But no matter what, a plan should always include data, and it should always include a time to analyze that data, or else they are not actually performing applied behavior analysis strategies. All right. Typically, those running the plan are registered behavior technicians or RBTs, as you'll have hear them called. This designation means that they've received a minimum of 40 hours of training. They've passed a competency assessment with a board certified behavior analyst, and they've taken an exam from the BACB. Once they are certified, an ongoing 5% of the time that the RBT is working in a behavior analytic program must be supervised directly by their overseeing BCBA. So with regards to this, you're going to want to talk to your BCBA about your RBT's degrees, their experience with skill acquisition, management of problem behavior, and then general experience with children as well as how and when supervision will be provided. It is not to say that a new RBT or an RBT who doesn't have a lot of experience with young children can't be very effective and good at their job. But if they have less experience, I would certainly want them to have more supervision when it comes to working with a new population. If they've had or more experience, then that minimum 5% may be reasonable. No matter what, the RBTs should be getting ongoing supervision. All right. So now these next few slides are going to jump into the methods utilized within ABA. And the way I broke this out was by addressing concerns that caregivers or parents have brought to my attention when they're looking into an ABA program. Once I identify the concern with you, I'm going to talk about what a good program should look like and how they address this concern. If you're going to start ABA therapy, it might be good to jot down a list of all of these concerns so that you can bring them up and see how your particular provider addresses them. So the first concern I've presented is that ABA makes them work at a table all day. So table work may be part of the program, but only to this extent. Only the extent that it is appropriate for the task, such as you need a flat surface to color or to eat or to lay out your array of Pokemon cards, all right? The extent that it is appropriate for the goal, so needing to learn how to sit in order to transition to your next setting in kindergarten. Kids sit in kindergarten. They sit for circle time. They sit at desks. They sit at the cafeteria for lunch. So that's a skill that your child will need to perform upon entering kindergarten. And if they don't have it now, then they'll have to learn and practice that skill. And lastly, the extent to which it is appropriate for the learner. So is it appropriate for their sensory needs to sit in a regular chair? Or do they need something that gives a little bit more movement? Is it age typical for their development? It would not make sense to teach a 2-year-old how to sit appropriately at a table for the extent and duration that it would be appropriate to teach a kindergartner to sit at a table. ABA as a practice is not defined by the location it occurs, and skills can be taught on the playground, on a walk, playing on the floor, really anywhere. When you are considering an ABA program, I recommend that you tour the center if it will be a center-based program. Otherwise, they'll be at your house. So you have a little more access to what goes on in the settings of that. But if it's at a center where they'll be working, go ahead and tour it and then ask about pop-in observations. If they say they don't allow pop-in observations, that is something that I would consider greatly to be perhaps not right for me and my family. Um, Now, with that said, we can get a lot of what we call reactivity if a child were to see a parent peeking in the window, meaning they'll perform in a certain way or they'll react in a certain way. And our goal is to give you a very clear access and visual of what they're learning. So often we'll ask parents to just give us a heads up with like 2 minutes before you pop in the window so that we can kind of move them to a part of the room where they won't see you, won't become upset if you're not taking them home, for example. But outside of that, having clear access to your child and what they're working on should be a component of the program. The next concern is ABA only involves rote repetitive learning drills. Repetition has been proven to effectively teach skills, so sometimes that might be part of it, but the way in which they practice that skill should vary to maintain the child's motivation to learn and participate. In other words, we should not be doing things that bore your child or make learning aversive because they have to do it so much. Drilling a skill should never be the technique. Skills can be taught in play, any activity that the child is engaging in. This technique is called natural environment teaching, and we talked about it with regards to the brief history in the earlier slide. You'll often hear it called NET, and it should be, when you're reading that plan and program put together, described as some part of every child's program. The next concern is an RBT will make my child do tasks. An ABA program should always emphasize a child's assent to participate. The RBT has to engage in rapport building not only upon meeting a child for the first time, but really the start of every session to ensure that they are comfortable to begin tasks that may be challenging for them. Any prompting methods which might be used to help a child complete a task should be discussed at first with the family for informed consent. So they shouldn't be engaging in any sort of prompting methods that you are not aware of or that the child would find aversive. Time delay should be a frequent procedure used in the program. And a BCA should be able to describe its use effectively. So I encourage you when you're looking at ABA programs to say, hey, can you tell me a little bit about how you might use time delay? For one, they're going to think that's awesome that you know that term. What it really means is that when presenting the task, you allow a child who is known to have the skill the time to complete it without prompting. This prevents a power struggle that could potentially occur. It demonstrates patience and trust from the RBT, and it helps build the RBT client relationship. Lastly, it prevents the need for any physical contact. So, if they are able to say, hey, do this, and then just give them the time to process and do it, and they do it on their own, and then we give them great things for doing it, that's how we want it to look. We want to avoid hands-on when possible, and we want to give bigger and better things for the child completing something independently. So not only will you look smart, but you'll also let the BCBA know that you have a grasp on what appropriate programs look like, and you expect that for your child as well. The next one, and we do hear this quite a bit, is ABA bribes my child to do things. So a little of this is about education between the difference between a bribe and positive reinforcement. So an ABA program should always incorporate and rely heavily on positive reinforcement strategies. Bribing, on the other hand, is more like dangling a carrot in front of somebody, a carrot being, a treat or preferred activity or something, when they are actively not doing a desired task. So they're actively engaging in refusal, and we're saying, hey, if you stop doing what you're doing, you'll get this. Reinforcement differs in we set the expectation in advance. We're looking for good behavior, desirable behavior, and functional behavior. And then once that behavior occurs, then we're offering great things in return. Refusal and other problem behavior related to escape wouldn't result in a reinforcer. As part of an ABA program, preferred items and activities should be routinely assessed. We call these preference assessments. And those things should be rotated so that we can maintain that motivation. When you're looking or interested in an ABA program, ask your BCBA how reinforcement is incorporated and then what reinforcers are provided. We want to be cautious about heavy reliance on food or things like screen time. While these can be identified as effective reinforcers for kids, and as a parent, you have every right to allow those things, we also want children to learn that there are great things occurring as part of their natural environment for learning these skills. For example, if you greet a peer, we want the reinforcer to be that peer noticing you and saying hello back to you, and then perhaps some interaction or friendship develop. That's the reinforcer we're going for, not necessarily you greeted someone, so now you get a Skittle. Okay? Now, those things may be used initially to teach the skill, but if we're looking to effectively generalize it into natural settings, we need to be looking for natural reinforcers as well. Another concern. ABA has no concern about my child's feelings or sensory needs. An ethical ABA program should always consider a child's physical and emotional needs and well-being and emphasize their dignity. Any changes in behavior excesses, so things we're looking to decrease, or deficits, so things we're looking to increase, should be addressed if they prevent learning or participation in the child's environment. So a few examples. A child that may engage in some hand flapping when they're excited, if there's no detriment to the learning environment and they're still able to be included with their peers in appropriate social settings, there is no socially valid reason that we would want to go in and decrease that behavior. Another example that parents have concerns about because it was something that used to be targeted many years ago, requiring prolonged eye contact as this sort of contrived measure of attention and respect within a conversational interaction. Eye contact can be reinforced when it occurs, so that we're pairing that behavior that might promote a skill of joint attention, for example, but targeting levels of eye contact at really inappropriate levels, and especially at the discomfort of a child, would not be ethical. And I really like to think, especially for this one, as an adult in the workforce, with kids of my own, when I have conversations with other people, I don't just stare at them for extensive periods of time. I might look away. I might look up, trying to think of, the thought that's coming into my head so I can express it. Extensive eye contact might actually be deemed inappropriate if I don't blink or look away. So I want to give the same same thing to the kids that we are teaching, and the same respect and thoughts when we're building programs for them. Another example might be teaching an appropriate alternative to covering ears and putting their head down. Um, might be socially valid for a child that's missing out on teaching opportunities during school. Okay, so if they're missing out on a lot of those teaching opportunities because they're shutting down and closing their eyes and covering their ears, we might want to teach that child not just to stop doing that, because that doesn't help, but an appropriate alternative to request a break or to ask if they can reduce the volume in the classroom, whatever a reasonable target would be. Now, in turn, there may be a decrease in ear covering and, closing their eyes and putting their head down. We may see a decrease because they have other appropriate alternative ways to address that concern and issue and feeling for themselves. All children, no matter what, no matter how many hours they've got, no matter what RBT they're working with, no matter if they're in the community or in center or at school, they should all regularly experience empathy, concern, appropriate touch from caregivers like hugs and high fives, throughout their day from the people that are around them. That includes their teachers and their peers. It should be a learning environment in which they want to be and want to participate. All right. The next one. ABA wants my child to be like everyone else. In reality, an ABA, an ethical ABA program, should only target changes in behavior that are critical to the child's learning and functioning in their prevailing environments. So kids who are really good at things, like I put some examples from some of the children I've worked with, things like the Greek alphabet or math facts or dates or dinosaurs or past presidents, or I could go on and on really, is incredibly awesome and it should be encouraged. We also, on top of encouraging those interests and those skills, should also be teaching social flexibility, like listening to your peers, letting others talk about their interests as well, seeing if they can broaden their interests. Because if they don't have access to new movies or new food or new experiences, then it's really going to restrict their environment and their access to other environments. So we still want to teach that as well. I really want to leave this slide um, with this last comment, and I hope that this hits home for everyone. A child's unique personality and interests should never be extinguished. Never. If we're talking about ABA or not, it's something that should be encouraged. But with that said, it should be shaped in a way that they can effectively share those interests and likes and desires and dreams and hopes with family and peers who will hopefully in turn appreciate those unique qualities. So in summary, a solid, ethical, high quality ABA program should include thorough assessment and reassessment, individualization, informed consent. And I say that I'm part of the family, but also if a child has the ability to pick and choose some parts of procedures and show preference for the way things are taught, assent and consent in that way should be regarded as well. It should heavily rely on positive reinforcement. It should have a component of data collection and analysis. And then it should be very clear how they're going to generalize those skills into settings that the children need to function and thrive. And then as far as expanding on that basic ABA program and including compassionate care, the learning environment should be varied and engaging so that we're maintaining that motivation and promoting assent from the child. The teaching methods should be individualized in order to facilitate attending, fast acquisition, and comfort in their learning environment. The learning environment should be a place the child chooses and wants to go, as opposed to us making them be present in any way. All of the caregivers, RBTs, or anyone involved with the program should work hard to build rapport with the learner. They should feel comfortable with everyone who is part of the session. Regular informed consent should be a habit of being offered by the BCBA and required by the caregivers. So be sure your BCBA, you are involved with them and you have their phone number and you have their email and you are regularly communicating with them. Reinforcement should be faded and it should evolve to naturalistic items and events. So we talked about that a little bit earlier. And lastly, children are human beings worthy of and requiring dignity and respect, and this should be evident throughout the interactions, procedures, and processes of a quality ABA program. Here are some references. If you want access to any of these things, feel free to reach out. I'd be happy to get them for you, but they're also available online. And thank you for your time and participation. Here is my direct number to Behavior Support Services, as well as my email address if you'd like to reach out or you have any additional questions.